Unboxing Careers.
Welcome everyone to the Unboxing Careers podcast. I'm your host, Greg Zackwitz. On today's episode, we explore the career of a vascular surgeon with Dr. Lily Johnston. Lily, welcome to the show. Thank you for being here.
Thank you so much for having me, Greg.
This is going to be fun. You are much more versed in YouTube than I am with the videos. So if you haven't checked it out, we'll get into this a little bit later, but I love your channel and I have a irrational death of dying from a heart attack. So I love your stuff.
Oh, thank you.
Not to start, we're going to start morbidly here, but so Lily, let's start with this. Let's do a quick level set here. Can you quickly tell us about your current role and how long you've been in the medical field for?
I am a vascular surgeon, so I operate on blood vessels in the body. I have kind of been in the medical field my whole life. It feels like my parents are both physicians as well and surgeons. So, I don't remember a time where medicine wasn't a part of my life, but truth be told, I started my medical school training in 2008, and it's been a long path to my full-time practice, but that began in 2021.
Perfect. And I was going to ask how and when you decided on this as a career. You mentioned both your parents are in the medical field, so I'm assuming it wasn't ingrained in you, but it was always around. Did you know at an early age that looking at your parents, that's what you wanted to do? Or is it something that you just kind of naturally always gravitated back to?
I always loved the science, and I always loved the idea of being able to use that to help people in a very concrete way. So it was a very natural thing for me in some respects. This is where I am meant to be. I firmly believe that right now in 2026, I am doing what I am meant to be doing. And I actually think in some ways, I wish I had looked a little harder at things besides medicine just to make sure that it was exactly what I wanted to do. And I thought about basic science, meaning being a scientist in a laboratory environment and really focusing on research and publishing papers. And that was about the extent of my creative exploration of career. So I really love the idea that you are helping people to create this safe space to ask the questions and explore this idea. I think I should have done a little more due diligence when I was younger, but this is, I always looked up to my parents. I thought what they did was so cool. And I did toy around with other areas of medicine besides surgery, but it didn't really ever occur to me not to be a doctor.
Do either of your parents do surgery, and did either of them work in the vascular side of things?
My mother is an obstetrician gynecologist who mostly focused on the gynecology side of that field, but she is an amazing world-class surgeon. My father is a cardiac surgeon or cardiovascular surgeon, and we can talk about that distinction a little bit later from the previous generations. But yes, and I thought I was going to be a heart surgeon like my dad for a while until I got into my training.
Okay, so you didn't fall very far from the tree then.
Nope, not at all.
So unlike some other professions, the education, normally walk through a typical education, but let's go into your particular field. Obviously, you're going to medical school. Give us just a super quick high level. How many years are we looking at for school? Are there any particular either classes or tracks that you need to go into, either if you want to do surgery or vascular medicine or a combination of those two?
Absolutely. So it probably goes without saying, but a 4-year college degree will be required to get into medical school, as well as the MCAT and a bunch of prerequisite courses. And then medical school itself is another 4 years. That gives you the MD after your name. And beyond that, you then need to do a residency, which is essentially an apprenticeship for many years where you get trained as people above you show you the ropes and help you learn to do something risky and, in some ways dangerous in a safe and controlled way. That process takes anywhere from 3 years for some of the medical specialties, upwards of 9 to 10 years for the surgical specialties. There are 2 pathways now for vascular surgeons to train. One is a dedicated vascular surgery residency that is 5 years. Some of that will be general surgery education as well, but it's truly a dedicated pathway that's shorter. So 5 years doesn't sound short, but it's actually shorter than what I did, which was to go through general surgery first, which is its own 5-year clinical residency. Mine actually took 7 because I spent 2 years doing research and getting my master's. And then I did a separate 2-year vascular surgery fellowship on top of that. So if you were doing the math, for me, that was 9 years of post-medical school training to get to be a fully fledged vascular surgeon.
Why did you follow that path? Was it just you weren't sure exactly what you wanted to do? Was there a particular reason you chose to go that way?
Out of medical school, I thought I was going to do cardiac surgery like my father, and that was my passion, and where I had done a lot of my research and my what we call sub internships, or my fourth year medical school, dedicated extra time in training to really, dive deep into a specialty. And I went to a general surgery residency that had an excellent cardiac surgery fellowship and a slightly accelerated pathway into that field so that you could have a little bit more dedicated time doing the cardiac surgery piece. I actually applied to some integrated cardiac residencies, meaning no general surgery, just the cardiac piece. And at that time, I didn't think that they were quite as developed as I wanted them to be. They didn't have quite as much structure and social support. General surgery, there's 5 or 6 or 7 people per class, depending on how big your residency is. And there's a lot of learning that happens amongst your peer group, not only just from your teachers, the full surgeons above you, but also within the program itself. And I didn't think the integrated programs had that. So I started in general surgery thinking I was going to do cardiac. And then as I rotated through vascular, which was a required part of my training in general surgery, I really had my eyes opened. I just hadn't had much exposure to it in my medical school training, and I didn't really know what I was missing. And the vascular surgeons took me under their wing and they said, let me show you what we do, and look how cool this is, and don't you want to be doing this, and isn't this fun, and let's help you get some more research, and let's help you spend some more time on service, and like do these parts of the cases that you can do. And they really showed me how much fun it was going to be a vascular surgeon.
So it was more of a love of something versus a dislike of something else that pushed you that way. Is that a fair way to kind of?
That's absolutely fair. Yep.
So that it's one of the common things we see across this podcast. People say, "Hey, I started doing this and I hated it," and they navigated over to this other side. So a lot of the good things is experimenting to try to figure out what you don't like. But I love that you did that and you found something that just naturally appealed to you, right? So you have the interest. You mentioned earlier on, Lily, about a difference between vascular and cardiac. What is the difference between those? Because I would think my initial thought is, a vascular surgeon, they perform the open heart surgery. And you mentioned that it's not necessarily the case. So can you explain what the difference between those two
yeah, of course.
practices are?
And back in the day, right, in my dad's era, they were sort of one and the same. Vascular surgery as its own specialty is relatively recent, meaning it started in kind of the 1980s was its heyday. But before then, the cardiac surgeons who operate on the heart itself were also doing a fair amount of the early work in vascular surgery. And some of the general surgeons were doing that too. That's how it became that the original pathway to training in vascular surgery was through general surgery. That was also, by the way, how you got to be in heart surgery, was you started in general surgery and then you differentiated after that. So, in my dad's era, he would do open heart surgery and operate on the blood vessels around the heart called the coronary arteries, also the valves in the heart that can wear out or become diseased, but also the blood vessels in the neck that feed the brain called the carotid arteries, or the ones in the leg that can get blocked. And he could do bypasses and all of that. Today, heart surgeons really just focus on the heart in the chest and the aorta that just comes out of the heart, that first part of the huge big blood vessel that leaves the heart called the aorta. And so they are almost exclusively working in the chest. So the coronary arteries are their territory. The valves are still their territory. But now every other blood vessel in the body that is not the heart and is not in the skull itself actually belongs to vascular surgery. So I'm the one who does the carotid surgery in the neck, or the blood vessels in the leg, the aorta in the abdomen, sometimes even in the chest beyond what we call the aortic arch. That belongs to vascular surgery. Anything in the skull belongs to neurosurgery or neurointerventional radiology. And then the heart, again, really belongs to the cardiologists and the cardiac surgeons.
Are there opportunities for people that say want to kind of cover both those, right? They want to do the open heart surgery, but they also have an interest in those surrounding areas like you talked about, right? Neck, things like that. Are there areas where people can go into and kind of do those things? Or are we more focused on specialties now? I'm assuming maybe rural hospitals and things like that probably have that overlap, but is that that overlap kind of a dying concentration?
I wouldn't say it's dying. I would say it's very niche. So the way that that looks
Okay.
most commonly today is somebody will do an integrated residency in vascular surgery. So what we call the 0+5 pathway, the 5-year vascular surgery residency, and then do a cardiothoracic surgery fellowship. I know a few people that have done that. Typically, they end up in very specialized academic medical centers that do very complex work in the aorta and in the heart. And more often people pick one or the other, both practically because the training pathways are long for both, and also because most jobs are going to ask you to kind of focus on one thing or the other, and it's going to be difficult to get a practice that encompasses both and makes that extra training worth your time and worth your while. But if it's your passion, there is absolutely a way to do it. And I think that's, if I had to leave people with one message, I have evolved in my career in surgery as well. We can talk about that and found my own niche, but you're never really stuck with whatever you've picked the first time. And as you say, people evolve and change over their careers, and there's a season for everything. And if what your passion is to do both, by all means.
Perfect. Appreciate the insight there. All right, so let's go back to, we've just gone through what you described as like 20 years. I'm exaggerating, but 20 years of education there. So now you're coming out, you've done your residency, right? You've kind of gone through that. Most people, I find, once they get through residency, are full-time employees of said hospital or healthcare organization and just kind of naturally progress into that. Can you talk a little bit about starting out? So if someone goes through kind of the track you went through, vascular surgery, get to that, what is their initial career looking like when they are full-time practicing doctors?
Right. And some of this gets into what the modern landscape in healthcare looks like. But for most people, you're going to end up taking a full-time position as a vascular surgeon. Most of the time, that's going to be with a hospital-based practice, meaning you're having a practice that involves an operating room, a hospital with an emergency department where you're taking call, and your days will be, sometimes you'll see patients in clinic. Other days you'll be scheduled for procedures, and either of those could be interrupted by an emergency. There are other jobs now for vascular surgeons that are outpatient based, meaning you don't really have a hospital that you're covering. You're just doing procedures in your office or in what we call an outpatient based lab, or the OBL. All that to say, those are kind of high throughput jobs. We're doing a lot of outpatient procedures, but you're actually not in the hospital. And those aren't very common yet, but they're becoming increasingly more available as the specialty develops and as we gain confidence doing things outside of the hospital for patients safely.
What's an example of one of those procedures that someone might just go in, like the outpatient ones you're talking about?
Maintenance of a dialysis fistula would be something like that, or a stent in the leg. So patients have the creation of what we call a fistula or a graft, usually in the arm, to support the blood that needs to get cleaned in dialysis if their kidneys don't work anymore. Those pipes can get plugged up over time. You can have areas of narrowing, or they can clog up. And that procedure to unclog them or to open up an area that's become narrow to that can be done in an outpatient setting, meaning you don't always have to be in a hospital to do that. And that's a good example of something that's done in the outpatient setting. I mentioned stents in the arteries sometimes can be done in the outpatient setting. A lot of the vein procedures. So people get confused about this. Arteries bring blood to the organs away from the heart. Veins bring blood back up to the heart. And vein stuff is very commonly done safely in a non-hospital based setting.
Gotcha. And then you mentioned your career path, right? So as people, as people kind of move through their first few years and get more and start advancing their careers, what is that? And maybe just use yourself as an example here. Talk about that career advancement. What are the types of things you can go into? I'm assuming whatever you are doing, right? The rotation is probably a bad assumption, but will change to some degree the more experience you have and seniority you have in your organization. So walk us through kind of an advancement a little bit. And if you want to just use yourself as an example, that's a perfect one.
I'm not sure if I'm a really good example or a really bad example for this. I am coming out with a book later this year that talks a lot about my first couple years of practice and this recognition that it wasn't what I wanted it or expected it to be. And so my first 2 years out of training, I took a full-time job in Northern California. And there's a lot of delayed gratification in medical training. You know, that's an arduous and, as I mentioned, long process for some of us. And you do a lot of this, well, it'll get better when thing. I'll put up with this for now, but it'll be better when I'm a senior resident instead of an intern, or it'll be better when I'm an attending instead of a resident. And there's a lot of this that happens. And it's a disservice to doctors and to healers in general, because, life is short and there should never be a period of your life where you're so miserable that you just can't deal with it. And it's not like life isn't worth living for you. So I thought it would be better when I had a full-time job and I was sort of more in charge of my schedule and my responsibilities. And it was better, but it wasn't easier. And I just wasn't what I wanted it to be. And I wasn't really satisfied, and I didn't love going to work every day, and I needed something different. So I quit my job and moved down here to Southern California where my parents live to help support my mom and dad. And that was really important to me to be able to do that. And I felt like I couldn't do that from up north. And I started working part-time as a surgeon and creating this other practice that I now have focused on prevention of vascular disease or cardiovascular disease. And it turns out that is really my passion. I like the surgery, and I still am really grateful to be able to serve patients in that way. And, I was in the OR yesterday and all of that. So it's, again, this evolution of understanding if it's serving you, and if not, figuring out how to fix it. But there's a lot of the medical training that teaches us our feelings don't matter, and our needs as human beings, like sleep and rest and connection, don't matter. And we have to unlearn that a little bit. Otherwise, our crisis of mental illness, depression, suicide in medicine will never change. And that's a big deal.
Would it be, I love the story, by the way, so thank you very much for that. Is it safe to assume that in most cases, if you're in the medical field and you don't like whatever situation you are in, because of the level of expertise it takes to be a medical professional, that there is an alternate path to something that is enjoyable? It's just a matter of finding out exactly what that is. Is that a fair assumption to make?
100%. And, I've known people who went through medical school and didn't do a residency and went into research or went into law or went into industry, like, device manufacturing or pharmaceutical manufacturing and the research behind those things. Consulting, there are hundreds of options. They are not as widely advertised, and there's a lot of, the amount of debt that medical students come out of school with is enormous. And I don't want to minimize the pressure that creates for people to generate income quickly to help themselves and their families potentially feel financially stable and secure, and to sort of dig themselves out of that hole. But there is always an option to do something differently. And whether that is, changing how you practice within clinical medicine, whether that is leaving clinical medicine, people within clinical medicine tend to create a little bit of a shame story around this. Like, well, you worked so hard. Why would you throw that all away? And I don't know why that is the frame that they use. I have some theories, and maybe those are not helpful, but at the end of the day, this is your life and there is nothing more precious, and you are here to do something in this world. And the best thing you can do is figure out how to be your best self every day. And being a clinical doctor is too hard and too important to not show up as your best self every day, most of the time. And so if you are dreading going to work every single day as a doctor, you're not serving yourself or your patients or the nurses and staff around you. Like, that's not a great situation. And, we all have bad days, right? We all have really tough days. Yesterday was a tough day for me. I'm not going to lie about that. And most of the time I've come up with a way that my career now allows me to be a better person most of the time.
Oh, well said. Well said. I want to talk about that a little bit if we can. So can you break down as best you can? I know this will probably vary, but what a typical day and week look like for you? And then kind of on the backside to that, talk a little bit about work-life balance. And probably this will vary based on whether you're residency, early in the career, or more established. But if you can kind of marry those two together, that'd be great.
For, as I said, for a full-time vascular surgeon, probably a week typically looks like a couple of days in your clinic or in your office where you are seeing patients, and those patients are coming to you because they've already had an operation and you're checking on them after the fact, or they have vascular disease and you're trying to understand, or is it time to do an operation, or are we going to keep using medicines and lifestyle interventions to help manage the disease process? And then others are coming to you for consultation to talk about risks and benefits of a particular type of operation that you might be offering to fix a problem that they have. And then the other few days of the week, you are going to be doing procedures, and whether that is vein cases in your office, big open surgery in the hospital, doing endovascular or minimally invasive procedures with wires, catheters, and x-rays and stents. Those are sometimes done in the outpatient setting, meaning in the office or in an outpatient lab, or can be done in the hospital with some frequency. Those will be the rest of your days. And then you'll be checking on the patients that you've operated on who are in the hospital. You'll be asked to consult on other patients who are in the hospital for some other reason, who might have a vascular problem. And so your day is spent doing some of that. If you are in the academic side, then you will be teaching and involving your residents and students in all of this activity and trying to help them grow and learn how to, be a fully fledged physician.
How is the early in the career? Is it decent work-life balance? Is it more focused on work than home life? And does that evolve as you become more senior?
The work-life balance is tough, and surgery in particular is a very demanding field. And I will say that this is part of the culture that I think is slowly changing in medicine, but maybe not quickly enough. There is residency, this idea of this apprenticeship process, is so named because a man called Dr. Halstead decided that his trainees needed to live in the hospital, and he built a dormitory at the hospital. And so they were in residence in the hospital. They didn't leave. And they were on, I think, every other night. And there's an old joke in surgery that my dad used to like to tell, which is, the only problem with being on call every other day is you miss half the great cases. And so there's this martyrdom culture, this idea that we have to grind and be here all the time. And it's a worthy sacrifice, that you don't need your partner or your spouse or your kids will see you later, and this is your time to really dedicate yourself. But if that's a decade of your life, that's a big ask. And I think that there's a generation of surgeons who have fourth wives and several stepchildren who may or may not speak to them, and and they were brilliant surgeons, don't get me wrong. They were dedicated to the art and craft of surgery, and they did more operating than most of us will ever see in the current modern era. But the price was high, and some would say too high. I would argue too high. Because again, at that point, you're not really a full, complete human being. You are a surgery robot or trying to be one. And that's not balanced. So we are trying to achieve better work-life balance. And again, many of us are trying to figure that out one off at a time, because I would say, for specialties that have a lot of on-call burden, meaning emergencies, nights and weekends, that kind of thing, you're going to end up in the hospital more often than you want to be. And you care about your patients. Of course you do. And you want to be there to help them and take care of them. But it, even when you're not in the hospital, it weighs on you. I was up at 3 o'clock in the morning checking on a patient from yesterday because I couldn't sleep and I was thinking about it. So, the burden is real, and it's a high price to pay.
I was just going to say, my assumption would be that it sounds like it's not an assumption. It sounds like it's very difficult to kind of leave your work at work, right? It comes home with you. You just gave the example of waking up at 3 in the morning, or not waking up, but you couldn't sleep because you were worried about patients. Is that something that takes a while for someone to manage, whether it's through talking to a therapist or other sort of outlets, whether it's meditation or something like that? Or is it kind of always stay with you, that separation or non-separation?
Everybody's different. The closest friends I have still have this preoccupation, but I'm probably friends with them because they are like me in many ways. I know other people at my same career stage who don't have as much of a problem turning things off and sort of leaving work at work. But this is, part of the reason our culture is the way that it is because it's not just a job. Like, this is somebody's life. This is somebody's,
Right.
well-being, and they have family and loved ones, and like, this matters to them. Like, this is, it's one more day in the operating room for me, but for that patient, it's the most important thing maybe that has ever happened to them in their life, and I take that really seriously. So it's a difficult thing to leave that, and I'm not sure we're supposed to, but you have to come up with a way to be okay with the fact that this is a big deal, and that the moral cost and burden on you as a healer is quite heavy.
Very good. Well, maybe not very good, but thank you for the answer. How about competition in the field? So if I go into vascular surgery, should I expect to be heavily competing for roles, or are they, if you have the training, they're relatively available for you?
Like everything, the most sought after jobs will be highly competitive. If you want to live in a very, like, if you want to live here in San Diego, it's going to be a little bit of a tougher job market for you. But if the reality of medicine overall is that there is a shortage of physicians and specialists. There's going to be a shortage of vascular surgeons as our population continues to age. The burden of vascular disease is not going down, despite my best efforts on YouTube to prevent the progression of vascular disease. And so there's absolutely an enormous need. And if you are interested in doing this, there will be a job for you. Whether it's close to your family and exactly where you want to be in the country is a slightly separate issue. But overall, there is absolutely an enormous need to have more people come into the field and serve.
Perfect. And how about salary expectations? I know this will vary based on where in the country you are practicing, rural, large city, smaller city. But what's a typical salary range should a, let's just say mid-professional, mid-career kind of expect?
Yeah, it's really market dependent, and it's very dependent on how your system compensates you. Meaning, are they paying you based on how many procedures that you're doing, or are you salaried?
Yeah.
Are you in an academic center versus a community or more private practice setting? Salaries are ranging for vascular surgeons full-time now on the low end at academic centers and this is more early career, but I would say 200,000 to 300,000 is low end. The median for vascular surgeons in the country by what we call MGMA is about 550. And then at the upper end, people are making almost double that for very, very busy private practice groups. And that sounds like an enormous number, I would say, when you're early in your career or from the outside. And I would just remind everybody that doctors are usually coming out with $250,000 of debt on average or more. And have had 10 years of sort of not repaying that and all of this. So, the pay is good as a surgeon. And as I said, the price for that is that it's not a 40-hour-a-week job.
Yeah, I was just going to say, remember, kids, all the education that you talked about earlier. So,
right.
Someone's got to pay for that.
Yeah, you don't start earning that until you're in your late 30s, early 40s. Yep. By contrast, my cousin, who's a business attorney, started earning that in her 20s.
How about some essential skills and or personality or temperaments that would either make a successful or less successful professional in your field?
The people I admire most in vascular surgery are creative problem solvers. There's a textbook answer for most situations, but I have to say that vascular surgery is a creative field, and we're often asked to rebuild things that don't have an obvious solution, as opposed to some of the other surgical fields, which are mostly focused on taking stuff out. Vascular surgery is asked to reconstruct or rebuild the circulation in a way that serves the patient and allows them to maintain their dialysis access or keep their leg or whatever the case may be. So sometimes you just need to be creative and solve the problem in a new and exciting way. So being able to think on your feet and being a creative problem solver is essential. Vascular surgeons often work with a lot of other disciplines. So we work with the trauma surgeons, we work with the urologists, we work with the cardiologists and cardiovascular surgeons, the spine surgeons. And we are called into lots of operating rooms for bleeding, and we are asked to help with tumor resections and all kinds of different procedures. And so being able to work across specialties, being able to be a good team player and collaborate well with others is a good skill to have.
Very good. And how about, I ask you kind of two sides of the question. So what do you find to be the most challenging part of your career and the most rewarding part?
There are two sides of the same coin, actually. And the most challenging part is that vascular disease is unforgiving and patients are very ill, especially when it's arterial disease. The venous disease is less this way, but when patients have disease or plaque that builds up in the arteries, or their kidneys have failed and they are at risk for losing a limb, or they've just had a mini stroke and they want, to have a procedure to try to reduce the risk of a future stroke, like this is big stuff. And these patients have very real risks of complications, and they happen. And so when that happens, when you are at the head of the ship trying to steer this patient to a better outcome and it doesn't go well, that's an enormous challenge and burden. And sometimes, you take that personally, even though the patient has bad disease. You wonder if a different surgeon might have had a better outcome. And that's really hard. And watching people suffer is really hard. Like, we got into this work to alleviate suffering, and to watch that happen anyway is really a problem. On the flip side of that, a lot of the time we help, and a lot of the time we are able to alleviate that suffering, to provide comfort. And sometimes that's not even in the form of surgery. Sometimes it's in the form of reassuring patients that what they have doesn't need an operation right now, and that there is a lot of things we can do to help them hopefully avoid needing an operation in the future, and provide the education and reassurance that this is something we're going to manage together. And I've had a lot of patients who say, "Oh, thank you. I feel so much better after talking to you. I was so worried, and now I feel relieved." And that is a great day for me. That's a really good day. And so the ability to provide that is an enormous privilege.
That's lovely. Okay, I wonder about this all the time. I think about weird things like this, like who's the first person to eat a crab? Like, this seems like an odd thing, right? So I think about this with surgeons quite a lot. The very first time you perform surgery outside of like a practice setting, right? Are you extremely nervous, or have you been trained so well leading up to that it's just like another day?
It's both. So, vascular surgery is a cool field because we have a lot of evolving technology. And I was talking to some friends and family about this over Thanksgiving, because I had done a quote unquote new procedure for a patient, and it enabled her to, get better blood flow to her leg without having to have a big incision, which for her case was important. And everybody was just aghast that I had done this new procedure, and like, how did you learn to do it? And was this experimental? And what was going on here? And the truth is, it is a bunch of building blocks of other procedures that I do, all strung together in a new configuration. And I had a senior partner helping me, and he has a lot of experience above and beyond mine. We had the person who helps with the technology in the room guiding us through this. We had a very honest conversation with the patient, explaining to her what the options were, and was she willing to have this sort of newer procedure, which has a lot of data published in the literature. It's not like it's experimental. It's not, but it is newer. And I was nervous. I also had confidence that it was the right thing for the patient, and that it was the use of skills I already had, right? It wasn't like brand new and different than anything else I'd done. It was just a different assembly of other skills that I use every day. So, the evolution of technology, the development of these newer types of procedures can be done safely. And what we want to do is, again, have the best team around us, have a plan for what happens if it doesn't work like we expected, and be really upfront with patients about, what's going on and what we're doing, and be transparent and open about how the sausage gets made.
But for your very first surgery, you don't tell the patient, "Hey, you're my first one," though, right? You just act like you've been there before.
So the question is, what is your first operation, right? Was it in
I
medical
guess that's
school when
true.
they
Yeah,
let me
yeah,
close skin? Was it in residency when the attending left the room for the first time? Was it in residency when the attending was in the room and was telling me what to do, but was still there, sort of holding my hands intellectually, if not physically? And honesty is a big thing for me as a personal value. And so if people ask me, how many of these have you done? I will be honest and say, as a surgeon independently, it has been, you're my first one, but I have done about 150 of these in training over the last 10 years. And, if you would like a more senior surgeon, that's your prerogative, right? Like, this is a big deal. So I try to be really open and honest about that. But I also think that our training is so long and the graduated responsibility is so progressive over time that it's hard to know like your first one, because there are gradations of this. And even at your first one in practice, like if I'm doing something before, I'm almost certainly going to have that I haven't done. I'll have a partner with me who's been doing it a long time, or they're in the next room, right? They may not be holding my hand in this room, but they're next door. And if I get into a situation that I'm uncomfortable with, there is help and support there. So it's, if people ask me, will I say it? Absolutely, I will. And also I try not to offer people things that I don't feel comfortable doing or that I can't do safely. Like that's again, not a place I want to be for anyone.
That makes sense. All right, Lily, as we wind down here, kind of leave you with the last one around the career here, but what are some things that either people should know when deciding to go in this field that either no one tells you or that they're going to be surprised by?
I hope somebody tells every medical student in looking at surgical fields about this, but what somebody told me while I was deciding what I wanted to do was, if you like anything else as much as you like surgery, you should do the other thing. You better like surgery more than you like anything else, because the demand on your time and on your conscience and on your soul is so high that it needs to be worth it to you. So if you like anything else as much as you like surgery, go do the other thing, because it's probably easier. And it will take less of you to do it. So you better love it. And if you love it, it's worth it. It absolutely is. But if you are doing it for a perceived financial gain because specialists make more money, that's not going to be worth it to you. There's no amount of money that is worth the again, moral burden that we've talked about. And if you're doing it out of ego, you're going to be unhappy, because surgeons used to run the world in medicine, and now we are more cogs in a machine, and like the hospital administrators don't care. You are not that special. You can be replaced. So if you're doing it out of ego, you should probably let that go. Do it because you love it and because it's your passion. And unless that's your motivation, you're going to find that the amount of work that it takes to get there and to keep doing it is too much.
Because of this, in your experience, have you found that more people go into the surgery role because they love it, or do you find more people start off kind of in the surgery role and then back out of it because of those demands? Like, is there any correlation there, or is it really just you've seen it both ways and it's about?
I've seen it both ways. There are a lot of people who start through medical school who choose, again, to do something non-clinical afterwards, and people who are in residency and leave. We had a couple of residents in my program who switched to other specialties while they were training. And that's great. Like, that's fine. Find what you love. There's no shame in that. And, maybe you want to practice surgery for a few years and then do something else. That's also fine. Again, I come back to this idea of you have to do this own self-diagnostic quarterly or semi-annually and figure out, like, are you happy? Are you doing what you're supposed to be doing? And if the answer is no, how can you change and pivot into something where you are going to be a whole human again? Because that's a really big deal.
Perfect. And Lily, did I neglect to ask you anything that maybe is important for you think people should know?
No, I think, vascular surgery is a super fun and special place to be. There's a huge need. And if anybody is interested in learning more about it, I'd be happy to answer more questions offline.
Perfect. We'll get to that in a second. I've got to ask you a question first. So in your opinion, this is a health related question. What are the 2 or 3, you can keep the answer as short or as long as you want, 2 or 3 most important things, in your opinion, someone could do to improve their vascular health?
Exercise is probably top of the game. Our muscles are fed by our blood vessels, and just like our heart is a muscle, it's a use it or lose it thing. And people who have prioritized fitness their whole life always have better blood vessels and better outcomes with vascular surgery if they need it than those who do not. It's also just good for your brain. And I would say keeping up with your health, right? Understanding if you have a genetic predisposition, like a strong family history, and trying to get on top of that earlier in life. I think many of us in our working years don't prioritize our health, and we assume that we'll be able to catch up and fix it later with, vitamins or drugs or something. And that's not really true. What I see is that health is an investment, just like your retirement account is an investment. And small things like paying attention to how you eat and getting a little exercise in and getting some sleep and really investing in your health compounds over time, just like investing in your 401k compounds over time. And the time to start is today.
Perfect. Well, thank you for your time today. You mentioned contact before, so if someone does want to reach out to you, we'll link this all in the show notes on the website. But if someone wants to reach out, ask a question, check out some more information on you, like a YouTube channel, what are the best ways for someone to get a hold of you or find out more about you?
Yeah, the best ways to find me are through LinkedIn. You can find me there at L Johnston MD, or on YouTube, I'm at Lily Johnston MD, Johnston with a T.
Perfect. We'll link that all for you. So Dr. Lily Johnston, everyone. Hope you enjoyed today's episode. If you want to explore other careers or share yours with us, please check out our website. Until next time, go Bills, and finally, go Sabres. I'm